Okay, so let's start. We'll start with complement pathway. So the activation of complement pathway occurs via three pathways. One is classical, the second one is alternate, and third one is lectin pathway. So the classical pathway is triggered by antigen antibody complex containing IgM or IgG. IgM and IgG are the main antibody classes that activate the classical pathway. So the C1 is the initiating protein, and after binding to the Fc portion is able to activate C4 and C2, which in turn activate multiple C3 molecules. C1q binds to the Fc portion. So Fc portion is a crystallizable fragment. C2 is involved in activation via the classical pathway. The alternative pathway is initiated by certain antigens such as lipopolysaccharide, endotoxin, and IgA complexes on the cell surface, which activate the C3. The alternative, not the classical C3 convertase enzyme, involves C3b, which generates early innate response that does not require antibody for activation. So the lectin pathway, it is a mannose binding lectin. Lectin proteins bind to carbohydrates present on the bacteria. This indirectly activates the next complement component C2 and C4. So similar questions you can have, that a child has recurrent pyogenic infection. What is the most likely diagnosis? So mannose binding lectin deficiency. It is an acute phase protein secreted by the liver. MBL deficiency is thought to be the most common complement deficiencies. So low MBL results from mutation in MBL2 gene, 3 to 5% of the population, and heterozygosity in 30% of the population. Deficiency of MBL is associated with increased pyogenic infections, especially encapsulated bacteria due to defective opsonization. Increased severity of chronic inflammatory conditions. So this is a picture depicting the pathways of complement activation. So you can see the three pathways are shown. Each one leads to the generation of activated C3b. So the classical pathway is triggered by interaction with the antigen, you can see. Okay, so the three pathways of complement activation are shown. Each leads to generation of activated C3b. The classical pathway is triggered by antibody interacting with the antigen, and the lectin pathway by the lectin binding to the sugar. The alternate pathways turn over continuously. Activation of the complement system leads to inflammation, release of anaphylotoxin C3A and C3-5. So later on we will read about their association with some meningococcemia, membrane perturbation, and lysis by the membrane attack complex C5b and 9. And opsonization, deposition of C3b and C4b. So MASP means mannose binding lectin associated serine protease. So all complement pathway have one final common pathway at C3. So whether it is the classical pathway, whether it is the lectin pathway, alternative pathway, so they all have a final common pathway at C3. And C3 that leads to opsonization, inflammation, or lysis. So what are the complement inhibitors? So membrane bound complement inhibitor are CD59, complement receptor 1, decay accelerating factor, membrane cofactor protein. What are the soluble complement inhibitors? Factor H, C4 binding protein, C1 inhibitor, and factor 1. So coming on to hypersensitivity. So there are 5 types of hypersensitivity which you have to remember. The gel and Coombs classification divides hypersensitivity traditionally into 4 types. So type and examples are: type 1 is anaphylactic antigen reacts with IgE bound to the...
The slide is not changing, sir.
Slide is not changing. Now, doctor?
No.
Some problem, I think. Is it visible?
Yeah, it's visible.
Okay, so the Cell and Coombs classification divides hypersensitivity traditionally into 4 types. So types are mechanism. Anaphylactic antigen reacts with IgE bound to the mast cell. It is IgE mediated. So type 1 is IgE mediated. Then anaphylaxis, atopy, asthma, eczema, and hay fever are the example. And it is diagnosed by plasma tryptase. Protease, which tryptase is a protease which is released from the mast cell. Type 2 is a cell-bound IgG or IgM which bind to the antigen on the cell surface. So this is antibody mediated. So examples you have to remember. Like type 1 you have to remember asthma, eczema, hay fever. Type 2 autoimmune hemolytic anemia, ITP, good posture syndrome, pernicious anemia, acute hemolytic transfusion reactions, and rheumatic fever, pemphigus vulgaris. Type 3 free antigen and antibody IgG, IgA combine. Immune complex deposition occurs. Examples which you have to remember mostly serum sickness, SLE, post-streptococcal glomerulonephritis, extrinsic allergic alveolitis, especially in the acute phase. Type 4 is delayed hypersensitivity. So this one is the cell-mediated type, T cell mediated. Tuberculosis, tuberculin skin reaction, graft versus host disease, extrinsic allergic alveolitis, especially the chronic phase, multiple sclerosis, and GBS. So few examples you have to remember of each type for exam purpose. And in recent times, a further category has been added, which is type 5 antibodies that recognize and bind to the cell surface receptors. This either stimulating them or blocking the ligand binding. So examples which type 5 you have to remember is Graves' disease and myasthenia gravis, very important. So this question has come several times, type 5. So what is the hallmark sign of mast cell degranulation? It is the classical peel and flare. So anaphylaxis. So anaphylaxis is caused by type 1 hypersensitivity. Immunoglobulin E is the most common immunoglobulin involved in the pathogenesis of anaphylaxis, mediated by histamine 1 receptor stimulation. Antigen production of IgE, which initiates the event, as we have learned that IgE is involved here, can be associated with leukotrienes B4, C4, D4, and E4. So these are the mediators that make up the slow reacting substance of anaphylaxis. It usually takes 15 to 13 minutes from the time of exposure to the antigen. Flushing, warmth, and tingling are the typical initial symptoms. So at least the 50% of the fatalities are due to respiratory complication, and more than 20% will have a second episode within 8 hours. So the mediators which are involved in development of the anaphylaxis include histamines, leukotrienes, prostaglandins, and platelet aggravating factors which are generated by mast cell degranulations. So other additional factors which are included are tryptase, chymase, heparin, chondroitin sulfate, interleukin 4, interleukin 13. So these are thought to be important in driving the onward cascade of inflammation to other immune system cells and contribute to the severity of the anaphylaxis. So Th2-CD4 positive lymphocytes are involved in the pathogenesis of anaphylaxis via the production of interleukin 4 and interleukin 13 that acts on the B cells to increase the IgE production and precipitate the development of acute hypersensitivity. Interleukin 4 also exacerbates anaphylaxis by acting synergistically with other vasoactive mediators to increase vascular permeability. So common identifying causes of anaphylaxis. So mast cell mediator release can be triggered by both IgE and non-IgE mediated factors. Therefore, anaphylaxis may be termed anaphylaxis, which is IgE mediated, or anaphylactoid, which is non-IgE mediated. So IgE mediated because of food, nuts are the most common cause in children. Drugs, the most common IgE mediated triggers are drugs, typically penicillin or other beta-lactam antibiotics. Neuromuscular blocking agents, vecuronium, are responsible for 60 to 70% of the allergic reactions related to anesthesia. The antigen responsible is thought to be the quaternary ammonium group that is found in other drugs, foods, cosmetics, and hair products. And venom, wasp sting. Anaphylactoid non-IgE mediated. So anaphylactoid reaction are defined as those reactions that produce the same clinical feature as anaphylaxis, but they are not IgE mediated. So non-Ig mediated causes include plasma proteins or compounds which are directly on the mast cell membrane, such as vancomycin, quinolone, aspirin, or other NSAID drugs, opiates, radiographic contrast media. Okay, so have the slide changed? Are you able to see the next slide features?
No.
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 Okay, so maybe because of we can only read in this format. Let's see.
Nice. Yeah.
Yeah.
Nice. Okay.
So features, the most common presentation of anaphylaxis is due to involvement of the skin. So dermographism is the physical examination sign that signifies a type 1 hypersensitivity reaction. So when the examiner applies pressure to the skin of a patient and writes a word, it remains imprinted as a erythematous wheal. So that is called dermographism. It occurs when a patient has urticaria, otherwise known as hives. So you may have seen in your OP the urticaria patient, they have dermographism. So investigation, most important, which you have to remember, is the plasma tryptase activity. So it's the most likely investigation to confirm the nature of reaction. So it have come as a question. The tryptase is the investigation of choice. Tryptase is a mast cell specific protease. Elevated tryptase implies mast cell degranulation. The greater the severity of anaphylaxis, the more likely that serum tryptase level will be elevated. Elevated serum tryptase level demonstrate that mast cell activation with mediator release has occurred, whether triggered by IgE mediated anaphylaxis or non-IgE mediated anaphylactoid reaction. So it has a half-life of 2 hours, peaking at 1 hour after anaphylaxis onset and return to baseline by 6 hours. So very important investigation is plasma tryptase level. And it is helpful in monitoring the diagnosis of anaphylaxis but does not elucidate the cause. So normal tryptase results do not exclude anaphylaxis and can be seen in serious reactions sometimes. Typically, the increase is less marked in non-allergic reaction, that is non-IgE mediated. Skin prick test usually carried out 4 to 6 weeks after a reaction to allow replenishment of histamine in mast cell granules. So we don't do skin prick test immediately. We do it after 4 to 6 weeks. Antihistaminic drugs must be stopped for 5 days, though steroids may be continued. A wheal of more than 3 mm in diameter, then the negative control is considered positive. And the presence of a flare or itching is also significant. Total serum Ig level is non-specific and unhelpful in these cases. So management, adrenaline is far the most important drug in anaphylaxis and should be given as soon as possible. So adrenaline can be repeated every 5 minutes if necessary. So the best site for IM injection is the anterolateral aspect of the middle third of the thigh. So this question has come several times. The site of injection, that the patient has got a IV cannula and he developed anaphylaxis. So where will you give adrenaline? So you have to take the answer that anterolateral aspect of the middle third of the thigh. It is recommended to observe patient after resolution of an anaphylactic episode for 24 hours for possible second phase reactivation. So that's why we advise the patient to stay in the hospital. An IgE mediated reaction such as asthma or anaphylaxis, what therapy inhibits the important reaction? Steroids. So the late phase reaction is due to attraction of T cells, release of leukotrienes and prostaglandins, often characterized by prevented by administration of hydrocortisone. So approximately 30% of the deaths related to anaphylaxis occur as a consequence of this late phase reaction. So next important topic is exercise induced anaphylaxis. So it's a rare disorder in which anaphylaxis occurs after physical activity. So features usually occur around 10 minutes after exercise and follow a sequence of pruritus, widespread urticaria. So pathophysiology may be related to endorphin release during exercise. So this question has come, endorphin release. The endorphin causes excessive histamine release from mast cells in susceptible individuals. Association cofactors such as food, alcohol, temperature, drugs, aspirin and other non-steroidal anti-inflammatory drugs, humidity, seasonal change and hormonal changes are important in the precipitation of the attacks. most associated with wheat ingestion. The food most commonly implicated in food-dependent exercise-induced anaphylaxis are patient can usually eat the causative food without problem so long as they do not exercise afterwards. So usually they eat some the food which are given, like after that they exercise wheat, shellfish, tomato, peanuts, corn. Towards the treatment, manage the same manner as anaphylaxis, usually resolve on stopping the exercise. Reduce physical activity to lower level may diminish the frequent attacks. Patients should be instructed on the proper use of emergency injectable epinephrine and have one available at all the time. Patient should wear a medical alert bracelet with instruction on the use of epinephrine. So next is anaphylactic reactions associated with anesthesia. So neuromuscular blocking drugs and latex appear to cause anaphylaxis more commonly in female patients. Individuals with history of atopy, asthma or allergy to some foods appear to be at increased risk of latex allergy, but not anaphylaxis to neuromuscular blocking drugs or antibiotics. So anaphylaxis associated with radiographic contrast media appears to be associated with atopy. Patients with asthma or taking beta blocking drugs may suffer a more severe reaction. So neuromuscular blocking agents, 60% of the cases of anesthesia-related anaphylaxis are due to neuromuscular block. Anaphylactic reaction due to neuromuscular blocking agent is more frequent and they occur without prior exposure. Quaternary ammonium ions are proposed to be allergic epitopes in neuromuscular blocking agents. Common environmental chemicals such as toothpaste, washing detergent, shampoos, and cough medicines share all these allergic epitopes with the NMDAs and predispose individual to become sensitized to quaternary ammonium and thus be at risk of developing anaphylaxis to neuromuscular blocking agent during anesthesia. Succinylcholine is the neuromuscular blocking agent most likely to be associated with allergic anaphylaxis. So succinylcholine you have to remember because it carries the highest risk because of its molecular shape and size. Succinylcholine. And mevacurium and atracurium are also associated with non-allergic anaphylaxis. Okay, so next important topic is oral allergy syndrome. So it occurs with stone fruits, apples, carrots, and potatoes. However, this only happens with the raw form as cooking denatures the allergen. The bark tree pollen season is usually in April and May, giving the typical rhinitis symptoms. So latex allergy can be associated with certain foods such as bananas, avocado, kiwi, and melon, but this allergen is heat stable. Most apples contain a considerable amount of salicylate, which can induce urticaria in aspirin-sensitive individuals. However, this is not usually associated with pharyngeal itching. Allergic contact dermatitis is caused by type 4 delayed hypersensitivity reaction to a chemical in contact with the skin. So oral allergy syndrome, you have to remember the cause, foods such as banana, avocado, kiwi, melon. These can lead to oral allergy. So the initial sensitization can occur 7 to 10 days after first contact with a potent allergen. However, it is more usually a consequence of many months or years of exposure to a small amount of the allergen. Once sensitized, contact with allergen can produce dermatitis within 24 to 48 hours. And all areas of body are usually... Doctor, can you please switch off your mic? Urticaria is a common condition and usually respond very well to systemic antihistaminics, which are the correct first-line treatment. Oral steroids can be given for severe cases, but only as a last resort. Blood testing include allergy screening is not routinely recommended in the management of urticaria, which can occur as a part of an allergic or non-allergic process. So coming on to tests, which we do for allergy testing. So skin prick test is the most commonly used test as an assay, is as an easy to perform and inexpensive. The first line for detection of allergen is specific IgE. So how it is done? Drops of diluted allergen are placed on the skin, after which the skin is pierced using a needle. A large number of allergens can be tested in one session. Normally includes a histamine positive and sterile water negative control. A wheal will typically develop if patient has allergy, can be interpreted after 15 minutes. Usually for food allergies and also for pollen. It can induce anaphylaxis and must therefore be done in an environment where resuscitation facilities are available. So skin patch testing is useful for contact dermatitis. So in skin patch testing, 30 to 40 allergens are placed on the back. Irritants may also be tested for. The patches are removed 48 hours later with the result being read by a dermatologist after a further 48 hours. Third is the radioallergosorbent test, which determines the amount of IgE that reacts specifically with suspected or known allergens, for example, IgE to egg protein. Results are given in grades from 0 negative to 6. So 6 is strongly positive, useful for food allergies, inhaled allergens, and wasp bee venom. Blood tests may be used when skin prick tests are not suitable. For example, if there is extensive eczema or if the patient is taking antihistaminics. So if the history of anaphylaxis is given, it would not be appropriate to perform a skin prick test. Thus, radioallergosorbent test is the most appropriate first line test to investigate the cause of the reaction. So when other tests are like skin prick test cannot be done, so the most appropriate test is radioallergosorbent test. Reason for false negative RAST test is immediately following anaphylaxis or allergic reaction, transient drop in IgE. So coming to latex allergy. So nearly 1 in 5 anaphylactic reactions may be due to latex allergy, more common than peanut allergy. Sensitivity to latex may cause a number of problems. Type 1 hypersensitivity like anaphylaxis can occur. Type 4 can also occur. Allergic contact dermatitis. Latex can induce allergy through IgE bound to the mast cells. Morphine, radiocontrast media, and colloid plasma expanders induce histamine release via their direct effect on the mast cells. So, latex fruit syndrome. So it is recognized that many people who are allergic to latex are also allergic to fruits, particularly banana. So, this question has come several times that a person who is allergic to latex, he has ate a fruit, after that he developed anaphylaxis. So options, many fruits are given. So the banana is the most common cause. Banana are most commonly associated with latex rubber allergy. Other fruits are pineapple, avocado, chestnut, kiwi fruit, mango, passion fruit, and strawberry. However, banana you have to remember. So a nurse who is known to have an allergy to latex develop a widespread urticarial rash and facial edema shortly after eating lunch. Which food is the most likely to have consumed? Banana. Peanut allergy. The sensitivity of a negative skin prick test to food is high. That is, for all nuts, skin prick test miss only 0.5% of the cases, whereas specific IgE will miss 22%. Less than 20% of individuals will grow out of peanut allergy, but they are usually those in whom the reactions are mild and started under 1 year of age. The wheal size resulting from the skin prick test is an excellent predictor of a positive food challenge to peanuts. Which feature is the most important predictor of anaphylaxis in asthmatic patients without peanut allergy? So, if they have a poorly controlled asthma, so that is the most important predictor. Poorly controlled asthma is an important risk factor for fatal anaphylaxis in this situation. Patients such this should have their asthma well controlled and have ready access to and knowledge of how to use self-injected adrenaline. Coming to serum sickness, it is an example of immune complex mediated hypersensitivity. Drugs are the most common cause. Classical features are rash, fever, polyarthralgias, polyarthritis, which begin 1 to 2 weeks after first exposure to the responsible agent. Symptoms resolve quickly upon discontinuation of the offending agent and prognosis is excellent. So treatment is symptomatic, short course of steroid are used for severe arthritis. Okay, so next we will read about immunity, the types of immunity, innate immunity, adaptive immunity. Then innate we have always immediate response. So what are the barriers? All this will read cell mediated humoral immunity. So coming to immune system cells, innate immune response. So what are the cells which are involved? So the cell type, functions and their properties. So neutrophil is the primary phagocytic cell in acute inflammation. So that is the primary cell, primary phagocytic cells. So granules contain myeloperoxidase and lysozyme. Basophils release histamine during allergic response. Granules contain histamine and heparin. It expresses Ig receptor on the cell surface bilobe nucleus. Mast cells present in the tissue and are similar in function to basophils but derived from different cell lines. Granules contain histamine and heparin, which also express Ig receptors on the cell surface. Eosinophil defends against protozoan and helminthic infection. So it is a bilobe, it has a bilobe nucleus. Monocytes, these are the cells which differentiate into the macrophages and these have the kidney-shaped nucleus. Macrophage involved in phagocytosis of cellular debris and pathogen act as an antigen presenting cell, major source of interleukin 1. Sorry. So natural killer cells induce apoptosis in virally infected and tumor cells, and dendritic cells act as an antigen present in cells but they have no cytotoxic potential. So question comes, which cell type is the most important antigen presenting cell during sensitization? So it is the dendritic cell. So dendritic cell is a key antigen presenting cell. After uptake of antigen, it migrates from the site of antigen uptake to the regional draining lymph node, where it presents proceeding antigen to T cells, stimulating either proliferation of established memory cells or differentiation of naive T cells reactive to antigen presented. Coming to macrophages. So macrophages are defined as a lymphocyte that is able to phagocytose the debris, toxin cells or pathogens. So most macrophages in the body are tissue macrophages. That is, they are allocated to a specific tissue where they will patrol for pathogen or housekeep, removing the cellular debris. Most tissue macrophages are positioned at the most likely entry points for pathogens. So types are tissue macrophages are either fixed or wandering macrophages which are able to scavenge or move in response to signaling. So what are the types of fixed macrophages? So these are the Kupffer cells which are in the liver lining the sinusoids of the liver. They account for nearly 90% of the tissue macrophages of the body. Pathogens from the intestine will first travel to liver by the portal venous system. And consequently, the Kupffer cells are positioned to engulf the bacteria, debris and endotoxins. Microglial cells are in the CNS, mesangial cells are in the kidney, osteoclast, macrophages of the reticular endothelial system. So what are the wandering macrophages? So macrophages of the serosal cavities such as pleura, peritoneum, pericardium and alveolar macrophages of the lungs. So coming to immunoglobulins. So first is IgG. 75% is monomer, comprises the majority of the circulating antibodies in the serum. So it's the major antibody produced in the secondary immune response, enhances the phagocytosis of bacteria and viruses. Half-life is 7 to 23 days, fixes the classical complement. Can bind to natural killer cell for antibody dependent cytotoxicity. The only antibody that can cross the placenta and enter the fetal circulation. So this question has come that which antibody is there that can cross the placenta and enter the fetal circulation. So it is IgG. So this is the most abundant isotype in the blood serum. So gamma is the type of heavy chain which is found in IgG. So next is IgA. So IgA 15% monomer and it can be also dimer. Found in secretions such as saliva, tears and mucus. So question has come which is antibodies found in saliva, tears and mucus. So IgA. Made primarily in the mucosa associated lymphoid tissue, provide localized protection on the mucous membrane. The Fc portion of secretory IgA binds to components of mucus and contributes to the ability of mucus to trap the microbes. Most commonly produced immunoglobulins in the body, but blood serum concentration lower than IgG. Half-life is 5 days, transported across the interior of the cell via transcytosis. Can activate the alternative complement pathway. Low levels of Ig are associated with increased incidence of celiac disease. So this you have to remember, this question has come that low Ig level is associated with celiac disease. Alpha is the type of heavy chain found in IgA. So IgM, it's 10% pentamer, first immunoglobulin to be secreted in response to infection. So again, the same question has come. Fixed classical complement pathway is most efficient. Anti-A, B blood cell antibodies, note how they cannot pass to the fetus. Pass to the fetal circulation, which could of course result in hemolysis. Monomeric forms of IgM are found on the surface of B lymphocyte as B cell receptors are sluggish, half-life about 5 days, slower half-life about 5 days. Mu is the type of heavy chain found in IgM. So IgD is 1%. It's a monomer involved in activation of B cells as a surface receptor on B cells, may play a role in eliminating the B lymphocyte, generating the self-reactive autoantibodies. So delta is the type of heavy chain found in IgD. Hyper IgD is associated with periodic fever, attacks of fever every 4 to 8 weeks with each attack lasting 3 to 7 days. Periodic fever. So IgE is only 0.1%. It is monomer produced by the plasma cells, mediates type 1 hypersensitivity reaction, binds to Fc receptor found on the surface of mast cells and basophils, provides immunity to parasites such as helminths. Least abundant isotype in the blood serum, half-life of 2 days. IgE may protect external mucosal surface by promoting the inflammation, enabling IgG complement proteins and leukocytes to enter the tissues. Cross-linking of cell-bound IgE. Cross-linking of cell-bound IgE by antigen triggers the release of vasodilators for the inflammatory response. The Fc portion of IgE made against the parasitic worms and arthropods can bind to eosinophils, enabling the opsonization. This is a major defense against parasitic worms and arthropods. Epsilon is the type of heavy chain found in IgE. Coming to transplant. Acute organ rejection is due to anti-IgG antibodies to the human leukocyte antigen. Incompatible tissues with primary activation of T cells. So rhesus antibodies are IgG, where ABO antibodies are IgM. Commonly recognized immunoglobulin changes in liver disease. Usually accompanied by decrease in albumin or IgG, increase in chronic active hepatitis, cryptogenic cirrhosis, IgM increased in primary biliary cirrhosis, alcoholic cirrhosis, and IgA increased in alcoholic cirrhosis. So hyper IgM syndrome, also known as CD40 ligand deficiency and X-linked condition. So it is a deficiency of CD40 ligand. The T cell defect presenting in a similar way to X-linked A gamma globulinemia with recurrent cyanopulmonary disease. Affected individuals are susceptible to pneumocystis jirovecii pneumonia. This you have to remember. Chronic cryptosporidial infection leading to sclerosing cholangitis and liver failure, increased risk of malignancy, particularly the abdominal cancers. Coming to hypergammaglobulinemia, what is the cause of hypergammaglobulinemia? Causes of polyclonal hypergammaglobulinemia, artifactual prolonged venous status after venipuncture. Hemoconcentration secondary to dehydration can lead to hypergammaglobulinemia. Chronic infections such as TB, infective endocarditis, leishmaniasis. Autoimmune diseases such as SLE and rheumatoid arthritis, ulcerative colitis and Crohn's disease, sarcoidosis and hepatic disease. So causes of monoclonal hypergammaglobulinemia, these are serious, monoclonal hypergammaglobulinemia. So multiple myeloma, you will have monoclonal hypergammaglobulinemia. Multiple myeloma is a type of cancer. Waldenström macroglobulinemia and heavy chain disease, leukemia, lymphoma, carcinoma, Benz-Jones proteinuria, benign paraproteinemia, amyloidosis. Coming to cryoglobulinemia. So immunoglobulins which undergo reversible precipitation at 4 degrees centigrade dissolve when warmed to 37 degrees centigrade. So 1/3 of the cases are idiopathic. Then there are 3 types: type 1, type 2, type 3. So type 1 accounts for 25% monoclonal IgG or IgM association with multiple myeloma and Waldenström macroglobulinemia. Type 2, 25% mixed monoclonal and polyclonal, usually with RF association, rheumatoid factor association, hepatitis C, rheumatoid arthritis, Sjogren and lymphoma. Type 3 is polyclonal, usually with rheumatoid factor association, RA, rheumatoid arthritis and Sjogren. Symptoms are present in high concentration. So Raynaud's is only seen in type 1. So this question has come. So when you, in which type Raynaud's phenomenon is seen? So Raynaud's is only seen in type 1 cutaneous vascular purpura, distal ulceration, arthralgia, renal involvement can occur. So what test you will do? Low complement level, especially C4 and high ESR will be seen in cryoglobulinemia. Treatment again with immunosuppression and plasmapheresis. Most important to remember is the type 1. And Raynaud's is seen in type 1. So where we use these immunoglobulin as therapeutics. So basic, formed from a large pool of donors, IgG molecule with subclass distribution similar to that of normal blood. Normal blood half-life of 3 weeks. Uses are primary and secondary immunodeficiency, idiopathic thrombocytopenia purpurea, myasthenia gravis, GBS, Guillain-Barré syndrome, Kawasaki's disease, toxic epidermal necrolysis, pneumonitis induced by cytomegalovirus following transplantation, low serum IgG levels following hematopoietic stem cell transplantation for malignancy, dermatomyositis and chronic inflammatory demyelinating polyradiculopathy. So these are the condition, GBS, which all you have to remember that can that where this immunoglobulin therapy is required. Coming to leukotrienes. So leukotrienes acts as a mediators of inflammation and allergic reaction. Just a second, doctor. Coming to leukotrienes. So leukotrienes are mediators of inflammation and allergic reaction. So their production is secreted by the leukocytes. They are found from arachidonic acid by action of lipoxygenase. It is thought that NSAIDs induce bronchospasm and asthmatic is secondary to the express production of leukotrienes due to inhibition of prostaglandin synthetase. So what they cause? So they cause bronchoconstriction and they cause mucus production. An important consideration in the pathophysiology of bronchial asthma. So increased vascular permeability attract the leukocytes. So leukotriene D4 has been identified as the slow reacting substance of anaphylaxis which causes bronchial wall and intestinal smooth muscle contraction. So that's why we give that montelukast, which is a leukotriene receptor antagonist. Okay, so what are the acute phase proteins? So this you have to remember. All of them like CRP, procalcitonin, ferritin, fibrinogen, alpha-1 antitrypsin, ceruloplasmin, serum amyloid A, haptoglobin, complement. During the acute phase response, the liver decreases the production of other proteins, sometimes which are referred to as negative acute phase proteins. So the above, the level will increase of CRP, complement and everything. And below the albumin, transthyretin, transferrin, retinol binding protein, cortisol binding protein. So they will have a decreased level during the acute reaction. So coming on to few antibodies, which are important for your exam. So NCA. So these are the two main types of anti-neutrophilic cytoplasmic antibodies. One is C-NCA, that is cytoplasmic, and second is P-NCA, that is perinuclear. For the exam, you have to remember C-NCA is in Wegener's granulomatosis and P-NCA is positive in Churg-Strauss syndrome, plus few others. C-NCA most common target is serine protease 3. So PR3 and C-NCA for Wegener's granulomatosis. This you have to remember. Some correlation between C-NCA level and disease activity is there. In Wegener's granulomatosis, it is positive in more than 90%. In Wegener's, the level of PR3 antibody and NCA titer are related to disease activity, and the antibodies typically disappear when the disease is in remission. Also positive in microscopic cholangitis in 40% of the cases. So coming to PNCA, it is the most common target is myeloperoxidase. So PNCA MPO in Churg-Strauss, you have to remember. Cannot use the level of PNCA to monitor the disease activity associated with immune crescentic glomerulonephritis in 80% of the patient. It is also positive in microscopic cholangitis, positive in 50 to 75%. Churg-Strauss, it is positive in Churg-Strauss syndrome, positive in 60%. Primary sclerosing cholangitis also positive. Wegener's granulomatosis, it can be positive but in only 25%. So C-NCA is usually positive in Wegener's. Other causes of NCA usually P-NCA are inflammatory bowel disease, Crohn's disease, connective tissue disorder, rheumatoid arthritis, SLE, Sjogren, and autoimmune hepatitis. So coming to few antibodies. So ANA. So younger women have often the low level of anti-nuclear antibody. So it increases with age. ANA positivity with antiphospholipid antibody suggests secondary antiphospholipid antibody syndrome, that is association with connective tissue diseases. The common test used for detecting and screening anti-nuclear antibodies are indirect immunofluorescence and enzyme-linked immunosorbent assay. Although the positive titers of 1:160 or higher are strongly associated with autoimmune disorder, they are also found in 5% of the healthy individuals. Positive titers of less than 1:160 are present in up to 20% of the healthy population, especially the elderly. Anti-Rho antibody, anti-La antibody are associated with Sjogren. Also, they can be seen in SLE with cutaneous involvement, but in 30% of the cases. So, anti-Rho antibody can cross the placenta and cause neonatal lupus in babies. So, this question has come several times that a newborn baby has developed a neonatal lupus, and what is the antibody that is associated? So, that is the anti-Rho antibody. Anti-Smith antibody is a very specific marker for SLE. So anti-Smith is 99%. So if question comes that which is the most specific antibody, so for SLE is anti-Smith. But the sensitivity is 20% and it is not associated with disease activity, anti-Smith. Anti-nuclear ribonucleoprotein antibody, anti-NRNP, also known as anti-U1-RNP, highly associated with mixed connective tissue disease. SLE in 30 to 40% of the patient. Anti-double-stranded DNA, anti-dsDNA are very specific marker for SLE, nearly 100%. Sensitivity is 85%. Correlate with disease activity in SLE. Also linked with lupus nephritis. So anti-dsDNA is 100% specific for this mixed connective tissue disease, or SLE. It is 100% specificity. And for mixed connective tissue disease, it is anti-U1-RNP. Antihistone antibodies. So antihistone antibodies are typically present in drug-induced lupus. Few drugs are there which can cause drug-induced lupus, such as isoniazid. So their antihistone antibody is positive. Unlike anti-dsDNA, these antibodies do not fix complement. So anti-centromere antibody is positive in limited cutaneous systemic sclerosis, also known as CREST syndrome. Anti-SCL70 antibody is associated with diffuse cutaneous scleroderma. So for limited, anti-centromere, and for diffuse, anti-SCL70. In pernicious anemia, gastric parietal cell antibody is positive, and in primary biliary cirrhosis, anti-mitochondrial antibody is positive. So these all names of the antibodies you have to remember by heart. The only two antibodies which have a role in monitoring disease activity, there is a correlation between level and the disease activity. So anti-dsDNA antibodies in SLE and CNK and Wegener's granulomatosis. So if the level is high, the disease activity is also high in these two cases. So coming to interleukins. So interleukin 1 is the key mediator of the immune response. It is secreted mainly by the macrophages and monocytes and act as a co-stimulator of T cell and B cell proliferation. Other effects include increasing the expression of adhesion molecules on the endothelium by stimulating the release of endothelium of vasoactive factors such as platelet activating factor, nitric oxide, and prostacyclin. It also causes vasodilation and it increases the vascular permeability. So interleukin is one of the mediators of shock in case of sepsis. So along with interleukin 6 and tumor necrosis factor, it acts as a hypothalamus. It acts on the hypothalamus causing pyrexia. So interleukin 1 causes pyrexia. Interleukin 1 beta level in the circulation are only detectable in the following situation: after strenuous exercise, in ovulating women, sepsis, acute organ rejection, acute exacerbation of rheumatoid arthritis. Interleukin 1 also plays a role in the formation of atherosclerotic plaques. The uptake of oxidized low-density lipoproteins by vascular endothelial cells result in IL-1 expression, stimulates the production of platelet-derived growth factors. Another is interleukin 2. So interleukin 2 is a member of cytokine family. It is a protein that regulates the activities of white blood cells. So what interleukin 2, it regulates the activities of white blood cells, leukocytes, often lymphocytes, that are responsible for immunity. So it is a part of body's natural response to microbial infection and in discriminating between foreign and self. Through its role in the development of T cell immunological memory, it also has a key role in enduring the cell-mediated immunity. There is some evidence that interleukin 2 may be involved in itchy psoriasis. High dose interleukin 2 can produce a high rate of response and durable remission in patients with metastatic renal cancer. Let's come to cytokine disorders. So both cytokines overexpression and underexpression or their receptors can be pathogenic. So underexpression and overexpression can be pathogenic. So in septic shock, production of interleukin 1, interleukin 6 and tumor necrosis factor due to endotoxin stimulation of macrophages following gram-negative infection. Toxic shock syndrome, massive release of cytokines due to super antigen stimulation of T cells by toxic shock syndrome toxin 1, a bacterial toxin. In Chagas disease, trypanosoma cruzi infection causes marked reduced expression of interleukin 2 receptors leading to marked immune suppression. So coming to interferons. So interferons are the cytokines released by the body in response to viral infections and neoplasia mainly. So they are classified according to the cellular origin and the type of receptors they bind to. So interferon alpha and interferon beta bind to type 1 receptors while interferon gamma binds only to type 2 receptors. Interferon alpha is produced by leukocytes and it has antiviral action useful in hepatitis B and C, Kaposi's sarcoma, metastatic renal cancer, hairy cell leukemia. Adverse effects include flu-like symptoms and depression. Interferon beta is produced by fibroblast, antiviral action. It reduces the frequency of exacerbation in patients with relapsing remitting multiple sclerosis. So that's why we give their interferon beta in their treatment of relapsing remitting multiple sclerosis. Interferon gamma is produced by T lymphocytes and natural killer cells. Weaker antiviral action, more of a role in immunomodulation, particularly the macrophage activation, may be useful in chronic granulomatous diseases and osteoporosis. Interferon beta, you have to remember, that is used in relapsing remitting multiple sclerosis treatment. So what are chemokines? These are the family of small cytokines or signaling proteins secreted by cells. Their name is derived from their ability to induce direct chemotaxis in nearby responsive cells. They are chemotactic cytokines, have 4 cysteine residues in conserved location that are key to forming their 3-dimensional shape. So homostatic chemokines responsible for basal leukocyte migration. So these include these and inflammatory chemokines released under pathological condition such as interleukin 1, TNF alpha, viruses attracting immune cells to the site of inflammation. Example are this you don't have to remember. May promote wound healing, promote angiogenesis. The major role of chemokines is to act as a chemoattractant to guide the migration of cells. Interleukin 8 is an example of CXC chemokine. This you have to remember. Coming to nitric oxide. Nitric oxide is previously known as endothelium derived relaxation factor. So nitric oxide has emerged as a molecule which is integral to many physiological and pathological processes. It is formed from L-arginine and oxygen by nitric oxide synthetase. An inducible form of nitric oxide has been shown to present in macrophages. Nitric oxide has a very short half-life, being inactivated by oxygen free radicals. Nitric oxide generates cyclic guanosine monophosphate. CGMP is the second messenger. So it acts on the guanide cyclase leading to raised intracellular CGMP levels and therefore decreasing calcium levels. Vasodilatation, mainly venodilatation can occur. Inhibit platelet aggregation. Clinical relevances. Underproduction of nitric oxide is implicated in hypertrophic pyloric stenosis. So this you have to remember. Lack of nitric oxide is thought to promote atherosclerosis. In sepsis, increased level of nitric oxide contribute to septic shock. Organic nitrates metabolism produced by nitric oxide is widely used to treat cardiovascular diseases such as angina, heart failure. We give that nitrolone. Sildenafil is thought to potentiate the action of nitric oxide on penile smooth muscle and used in the treatment of erectile dysfunction. Nitric oxide is also known as laughing gas, is often used in obstetrics and trauma for pain relief. Next, coming to endothelins and kinins. So endothelin 1 is a 21 amino acid polypeptide. It is highly potent vasoconstrictor and plays a part in modulation of vascular tone. It may have a role in diseases such as Raynaud's phenomenon. Its level increase when the endothelium is stressed, for example, trauma or oxidative stress. Other proteins activated during the tissue stress. Heat shock protein, which are also increased during tissue stress. Kinins are the potent vasoactive basic peptides involved in the inflammatory response. Their activation leads to release of chemotactic cytokines. The property of kinins used to be increased vascular permeability, causes vasodilatation, pain and contraction of the smooth muscle, stimulate the arachidonic acid metabolism. Coming to ESR. So ESR is a non-specific marker of inflammation and it depends upon both the size, shape and number of red blood cells and the concentration of plasma proteins such as fibrinogen, alpha-2 globulin and gamma globulins. So what are the causes of high ESR? Temporal arteritis, myeloma, very important exam point of view. Other connective tissue disorders such as SLE, malignancies, infections. Other factors which which causes raised ESR are increasing age, female sex, anemia. So what causes low ESR? Polycythemia and afibrinogenemia and hypofibrinogenemia. I think we can stop here today and we will continue in the next class with tumor necrosis factor. And we will also do few questions related to immunology. So this is a bit difficult topic, immunology, and more of you have to remember by heart, and you have to do many questions here. Once you start doing questions, you will keep on remembering few points. You will come to know that what kind of questions come in immunology, which important topics or which important lines in the theory you have to remember. So, okay, doctor, see you in the next class then. Thank you very much for your patient listening.
Thank you.
Thank you, doctor.